Cheer for Vania. Thank you.
So hi, my name is Vania. I'm a clinical consultant, mental health clinical consultant up in Gold Coast. I actually work with the QS, so I pair up QS correspondent, so I pair up with paramedics, and we go and respond to mental health calls. For the people in Victoria, I think it's called PACER, and also New South Wales is PACER. Today I'll be talking about building rapport with people in psychological distress. Be kind to me, this is my first time here. I've never been to an and the snow has been wonderful. And today I spent the whole day skiing, so hopefully my brain's still working and I still know what I'm talking about. In terms of background, I've trained in the UK 30-some years ago, and then I moved to Australia. I mainly work in, so I'm only mental health. Back in the UK, hospital training, only mental health. Only spent 3 months in a medical ward, and I did not like it. So I came over here. I mainly spent the last 25 years working in the emergency department as a mental health nurse. So doing mental health emergency call there, and 3 years ago I moved to the Gold Coast, and I've been there for the past 3 years. Any nurses know in oh my, it's only a few of you. Anyone from Gold Coast? Yeah. ET Gold Coast? Yeah? Okay. What about New South Wales? No? Have we got any nurses from New South Wales? Oh, what about you? Queanbeyan. Oh, Queanbeyan. Okay, all right. So I work in Sydney. So mostly, I was just trying to check here. Okay. Today I'll be talking about what is psychological distress, as I said. Talk a bit about why rapport it matters, the role of rapport in effective intervention, and look at some practical strategies for building connection. And also we're looking at the question at the end. What I want to ask you first is, what are some of the most common mental health presentations you will either provide ED nurses coming in, or I do know we have a few GPs here. No? Yeah, the reason I'm asking about the GPs is that you guys do a lot of work, and we have got a lot of our mental health patients pass on to you, and I know it's very difficult. So you guys do great work, and I know at times situations get quite difficult, and we're not always there coming and back you up, but I know it's hard, and I do appreciate, because we do have a lot. I do attend to a lot of GPs and stuff, and we do have a lot of our mental health. You guys take on. So I know that you have presentation over there as well. So can anyone tell me what sort of are the most common presentation you get?
Situational crises.
Yeah. GPs, do you have a lot of, do you get?
Yeah, stressed and depressed and
suicidal.
Yeah. Family issues.
Yeah. Would you say mostly people will have a lot of distress? People come in more distress? Yeah. And that's why the reason I'm looking at more psychological distress, because they will be one of the most presentations that you will probably will present to you. People will come in distress. Or even I do understand we have a lot of doctors as well. Even when you're looking at people presenting in hospital, you're looking at even on oncology or wherever, we talked about orthopedics, and when you are giving people some really difficult information or diagnoses, they're not going to sit there and smile, are they? They are going to get distressed, they are going to get very upset about it. Yeah? So psychological distress is not going to be just for mental health. you will find them on your day-to-day, and you will find them on every single ward. Whether we pick them, whether we identify it as something else. I know paramedics. What do you think? I mean, you talked about, is there any other, what are some of the other things you attend to? Yes, the situational crisis. Is there any other mental health that you find you attend?
Incarceritis.
What did you say?
Incarceritis.
What is that?
People wanting to leave Nunnambar Valley.
Yeah.
They want a day out on the Gold Coast.
Yes.
So, in English, what it means?
If you get arrested, you call the ambulance.
Oh,
You
okay.
say you're trying to kill yourself.
I didn't.
Go to hospital.
I didn't know about that. Okay. We do get it. I agree with that. Okay. I want you to think about the last difficult interaction you have. What made it hard? Just a few minutes, just think about something that it's a very difficult interaction you had with someone, and what it was about the interaction that was actually hard. Anyone care to share?
Drug intoxication.
Yeah.
Heavily alcoholically intoxicated people doing the loop.
Doing not even having to just doing the loop, so like you're talking about when you're talking to them, it's just back, like you're not getting much, and they keep repeating the same thing. And how do you manage that? What do we do about it? How difficult it is? I guess I'm thinking, what is it they do in the loop? What is it about it that's difficult for us? What do we find? How do we manage it? Do we find it difficult to manage them? Do we find it difficult to actually assist the person? What is it about it that's difficult? We can't reason with them? Is that what I'm saying?
Yeah.
We
The
can't.
ability to reason with them.
Yeah,
And
because
they can't follow the conversation.
they can't follow the conversation, they can't follow direction, so you're just finding yourself, it's like hitting a block. Yeah. So, I guess it's about, yeah, so.